2025 World Conference on Lung Cancer. I'm Brendan Stiles. I serve on the IASLC Communications Committee. Our committee, along with other IASLC members, really poured over 1,800 abstracts submitted to this meeting, and today's briefing represents 5 of the top-scoring abstracts and some of the most meaningful research and clinical advances in the field. We're privileged to have an IASLC patient research advocate, Charu Aggarwal, here with us today to provide his perspective as a patient coping with lung cancer. So please hold your questions till the end of the briefing and we'll get started. Our first presentation, I think, is really important and really newsworthy. It really seeks to unravel the mystery about why those patients who never smoke are diagnosed with lung cancer. With us is Dr. Elaine Shum from NYU Perlmutter Cancer Center, New York City. Dr. Shum's going to share the results of her study, Female Asian Non-Smoker Screening Study, FANS, a U.S.-based lung cancer screening program in a non-smoking population. Dr. Shum, welcome to the press briefing.
Thank you, Brendan, for that introduction. And we're honored on behalf of my co-authors to be presenting the Female Asian Non-Smoker Screening Study, also known as FANS, which is a U.S.-based lung cancer screening program in a solely non-smoking population. So as many in this audience knows, lung cancer in individuals with no smoking history is the 5th most common cause of cancer-related deaths worldwide. And we expect that the incidence of lung cancer in those with no smoking history to continue to rise in the next 10 to 20 years. In the US, current guidelines for lung cancer screening is offering low-dose CT scans, but only for those with a current or former heavy smoking history based on the National Lung Screening Trial. In Taiwan, the Talent study offered low-dose CT scans to those with no smoking history, but an additional risk factor such as family history, secondhand smoke exposure, and other environmental exposures. They reported an overall baseline lung cancer detection rate of 2.6%, and the lung cancer detection rate of invasive lung adenocarcinoma was 1.5%. The Female Asian Non-Smoker Screening Study, or FANS, was designed as a pilot study to assess the feasibility of doing a lung cancer screening program in Asian women with no smoking history. And here today we're going to be reporting the results from the baseline low-dose CT scans of our target and enrolled 1,000 participants in the study. So as you can see, here is our study design. Our inclusion criteria included women between 40 to 74 years old and identified as having Asian descent. However, we didn't include any other inclusion criteria that included other possible risk factors for development of lung cancer. After consenting participants underwent a shared decision-making discussion, discussing the risks and benefits of lung cancer screening, and then all participants underwent a low-dose CT test and also had a blood draw for a plasma-based cell-free DNA assay. The follow-up of the scans was according to lung rads as well as clinical decision-making. Again, this was developed as a feasibility study, and so we developed this database of clinical, demographic, and radiographic data of Asian women with no smoking history who underwent these low-dose CTs, and our secondary objectives included the lung cancer detection rate. Here you can see on the left the distribution of our lung rad scores for the 1,000 scans that were performed. You can see that the majority of participants had lung rads 1 and 2 at 38.8% and 52.1% respectively. A positive low-dose CT scan in our study was defined as lung rads 3 or 4, and this was 6.9% of all the participants. To put into context, the National Lung Screening Trial reported a lung rads 1 of approximately over 50% of participants, and a lung rads 2 was in the 30% range, which I'll get to later. Our lung cancer detection rate based on our baseline low-dose CT scans was 1.3%. About 23 participants overall did undergo a biopsy or surgical resection, and this did include 2 participants who had resection after their 3rd low-dose CT scan while on study. For lung cancers that were diagnosed based on their baseline scans, you can see here the stage distribution. 69% had a stage 1A lung adenocarcinoma. There were 2 participants that had stage 2B and another 2 participants that had stage 3B or 3C disease. As expected in a non-smoking population, all of the lung cancers detected were adenocarcinomas. Important to note is that there are actually 14 participants who did have a lung RADS 3 or 4 and have imaging findings that are highly suspicious for malignancy, and they remain in imaging follow-up at this time, perhaps suggesting that our lung cancer detection rate at baseline might be an underestimate. Here's a little bit more data on the lung cancers that were detected. You can see here that there was one participant that at their baseline scan had a lung RADS of 0. Their CT scan is depicted here on the right. Repeat CT scan showed that this became a lung RADS 2. However, putting together the clinical scenario and a discussion at our nodule board, it was recommended for the patient to undergo biopsy and was found to have a lung adenocarcinoma. All of the 13 participants that were found to have lung cancer were found to have a driver mutation. There was one participant that had 2 lesions, so 2 separate primary lung cancers on their scans. One had an EGFR exon 19 deletion and the other lesion an EGFR LA58R, giving us a total of 12 EGFR mutations detected. There were another 2 participants who were found to have HER2 exon 20 insertions. The majority of patients did not report a family history of lung cancer at 85%. On the right-hand side, I'm highlighting 2 other lung cancers that were detected on our study, and this was done after their 3rd low-dose CT scan. However, the lesions in question were there on their baseline low-dose CT scan. The first participant was found to have lung RADS 2 for the first 2 years on study, and this was upgraded to a lung RADS 4B due to a growing left lower lobe nodule, and ultimately it was found to have stage 1A lung adenocarcinoma with an EGFR LA58R mutation. The other participant had a strong family history of EGFR mutated lung cancer, was found to have a lung RADS 2 throughout the course of the study, but with discussions due to a persistent ground glass opacity, opted to have surgery and was found to have an adenocarcinoma in situ. Here's a summary table to put into context our results compared to the National Lung Screening Trial and the TALENT study. Things to note here is our definition of a positive screen does vary between the 3 studies. Of note, in the TALENT study, a solid nodule of more than 6 millimeters or a ground glass opacity of over 5 millimeters was considered positive, whereas in our study, we were following lung RADS, for which a lung RADS 3 or 4 was defined as a solid or part solid nodule of 6 millimeters or greater, or a ground glass opacity of over 30 millimeters or 3 centimeters. Again, this is something that we take into account when we think about our lung cancer detection rates, just given the different management guidelines that exist between the US and Asia. Here, just to focus on that a bit more, was looking at our ground glass nodules that were detected in our baseline scans. As I mentioned before, more than 50% of our participants did have a lung RADS 2 on their baseline scan, and you can see that of this, about 55 of those participants did have a ground glass opacity of over 5 millimeters. In TALENT, many of the ground glass opacities underwent surgical resection, so we're able to understand the histology of those ground glass opacities. And you can see there was an almost equal distribution of about a third to be found to have invasive adenocarcinoma, another third with minimally invasive adenocarcinoma, and another third with adenocarcinoma in situ. Again, underlying that the management practices between the US and Asia might represent perhaps an underestimate of the lung cancers that were detected in our cohort. So in conclusion, FANS does represent the largest lung cancer screening program detected to a non-smoking population in the United States, and we have demonstrated that this is feasible. Again, we reported a lung cancer detection rate of 1.3% from our baseline low-dose CT scans, which is comparable to TALENT that had a selected high-risk non-smoking population, and it is higher than the National Lung Screening Trial and the Nelson trial done in Europe. Again, all the lung cancers were found to have driver mutations underlying the different biology of lung cancer in non-smoking populations. And as seen here, just given different management guidelines, the development of specific screening and management guidelines for screening this population is definitely necessary as we continue to embark on this. And so again, as lung cancer in those with no smoking history continues to rise, considering to expand lung cancer screening to those with no smoking history certainly warrants identification of other high-risk groups who may benefit. Thank you.
Well, thanks so much, Dr. Shum. I think particularly powerful work that I hope will open the door to screening other high-risk populations. I hope to talk about it more in the question session. If you make it to the press briefing, you know that your research has been closely evaluated and is of the highest quality, and so to have 2 abstracts make the grade for an IASLC press briefing is quite remarkable. So we're fortunate again to have Dr. Nan Bi from the National Cancer Center of China, the Cancer Hospital of the Chinese Academy of Medical Sciences, here with us back again to discuss her research, Circulating Tumor DNA Refines Consolidation Immunotherapy for Limited Stage Small Cell Lung Cancer. Again, on this theme that we're really got in the era of using liquid to sort of monitor patient responses.
Okay, good morning, everyone. I'm Dr. Nan Bi from National Cancer Center. I think thanks a lot for the organizer to allowing me to present our work today. Our work, the title is Circulating Tumor DNA Refines Consolidation Immunotherapy for Limited Stage Small Cell Lung Cancer. Sorry. The phase 3 randomized adjunctive study has demonstrated the consolidation IO after concurrent chemotherapy has significantly prolonged overall survivals for limited stage small cell lung cancer and become the new standard of care. However, the effective predictive biomarkers and prognostic strategy, stratification strategy is lacking. Here we analyzed the 490 serial circulation tumor DNA ctDNA examples from 144 limited stage small cell lung cancer patients receiving concurrent chemotherapy with or without consolidation IO. The ctDNA dynamics during treatment were also assessed at different treatment time points, including baseline, post-induction chemotherapy, and pre-radiation therapy, and post-thoracic radiotherapy, post-PCI, and post-consolidation IO if the patients receive consolidation IO. The patients' characteristics included the most patients were majority male, 50, and concurrent. Sorry. Yes, concurrent or former smokers, and most patients were stage 3 disease at diagnosis. For baseline ctDNA mutation landscape, most patients had TP53 and IB1 gene mutations detection positive, and high concordance was identified between post-thoracic radiation therapy and post-PCI examples. The agreement rate is 88%. We identified that ctDNA dynamics could predict survival outcomes in limited stage small cell lung cancer. The positive ctDNA at pre-thoracic radiation significantly predicts inferior progression-free survival with hazard ratio of 2.46, and the positive ctDNA after thoracic radiation confirms poor prognosis with hazard ratio 2.20, and the persistent ctDNA positively, that means both positive at T1 and T2 pre and after thoracic radiation identified highest risk subgroup with hazard ratio 3. And early, it is very interesting to identify that early ctDNA status may identify patients benefiting more better from a consolidation IO. The ctDNA is after in 2 cycles of induction chemo and pre-thoracic concurrent chemoradiation. The PFS hazard ratio is 2.29, and the overall survival hazard ratio of 0.05, p-value less than 0.001. And the T1 ctDNA positive patients received consolidation ICI showed significantly improvement. We know the consolidation durvalumab can significantly decrease the risk of actual thoracic failure. If patients get ctDNA negative, that means response well to the induction chemotherapy, and maybe these patients can benefit less from the consolidation ICI. The most important, we developed a 3-level prognostic stratification strategy by integrating early ctDNA status and radiological tumor shrinkage to distinguish patients who benefit from the addition of consolidation IO. We found that those patients with ctDNA negative and the shrinkage more than 60% after 2 cycles of induction chemo was the low group, was belong the low-risk group and have excellent prognosis. These patients may have minimal ICI-IO consolidation benefit, while for patients with ctDNA positive and the tumor shrinkage less than 60% after 2 cycles of induction chemo, these patients may have worse median PFS of 10 months and will significantly benefit from IO consolidation. The limitation of our study is sample size and retrospectively analysis and relatively short follow-up of time for patients received consolidation IO. But we believe this data will provide valuable insights into the individual management of limited stage small cell lung cancer in the area of immunotherapy, and the independent prognostic study with large sample size is warranted. Thank you so much.
Thanks so much, Dr. B. That was really informative. I hope that we get a chance to talk about it more. Next up, we have compelling data from Dr. Chen, who's here to present research on molecular and early outcomes of a randomized phase 2 trial of primary tumor resection following EGFR TKI and metastatic non-small cell lung cancer. That's a mouthful, but I'll tell you for the press that this is really driven by biology and by patient preferences. This idea of stage 4 disease, which we typically treat with amazing therapies that work really well, but a lot of times we know those therapies fail and that there's persistent tumor cells there. I can't tell you how many times I've had patients with stage 4 say, shouldn't we just take the tumor out? And now Dr. Chen has asked that question in a randomized control trial. Dr. Chen's from the National Taiwan University Hospital in Taiwan. He specializes in lung cancer and the surgical treatment of oligometastatic non-small cell lung cancer. So welcome, Dr. Chen.
Hello, everyone. It's my honor to be invited to join this conference request. Today, I will introduce about the early result about our phase 2 trial about every patient in the metastatic non-small cell lung cancer patient after treatment with the EGFR TKI. We will analyze with the molecular and the early outcome in currency. And first, we will start from the rationale and the background from the primary tumor resection, because it's not so usual as the local consolidation therapy. And I think usually the main focus is about heterogeneity of the primary tumor. Because in our hypothesis, we think the primary tumor might be more heterogeneous compared with metastatic tumors. And for the purpose of resection, it might bring with the effect that the first one is to reduce the pre-existing subclone of resistance, and the second is by the debugging effect to remove the tumor and decrease the possibility of the induced drug resistance. So in our trial design, the primary tumor mainly is not for cure disease, not like in the early cancer. But in here, we want to treat patients with the prolonged treatment effect and the progression-free intervals. So in our study, we included EGFR mutant patient with stage 4 non-small cell lung cancer. The mutation type is about exon 19 deletions and LA58R. The performance status needs to be 0 or 1. In the treatment evaluation, we will let the patient take afatinib for 12 weeks and do with the restagens. At the time, we will let the patient do with the tumor progression if the partial response or stable disease, and we will assign to the randomization. And the ratio of randomization is 1:1, and for the intervention group, we will let the patient do with afatinib and plus the primary tumor resection. And for the control group, we will let the patient take the afatinib alone. And the primary endpoint about the 2-year progression-free survival rate. And for the secondary, the key secondary outcome is progression-free survival and the overall survival. For the trial setting, we will let the patient do with the primary tumor resection with the maximum regional control for the thoracic surgery. And for the disposition in the study, 91 patients was included and 19 patients was excluded due to the screening failed or the reason they don't want to keep participants. The randomization number of the patients is about 72 and 36 for each group. And in the demographic, we showed with balanced data, the median age about 13 years old for the patients, the female and the non-smoker are the majority in the study groups. And very important and interesting in this study setting, that we include the oligometastatic disease states also with the polymetastatic disease patients. And in this, but still, majority of the studies still remain as the oligometastatic groups. And for the surgical details, 2 patients refused to join the surgery, and for the surgical method, all of the patients received with the minimal invasive surgery. No patient with the convention to the thoracotomy. And for the surgical procedure, 76% of the patients do with the anatomical resection and remain do with the wedge resection. The median time from the drug to surgery is about 3.7 months. The nodal assessment is not mandatory, but about the 85% of patients still do with the lymph node dissection and do with the lymph node stapling. And for the surgical mobility, 1 patient with the massive bleeding and 1 with the prolonged hospital stay. But most importantly, most of the cases stay only for 4 to 5 days in the hospital stay. So in summary, the surgical after EGFR TKI is very safe for the patient. And for the pulmonary response, we can notice that the major pulmonary response was about 29% of patients, and the 2 patients with the complete remission of pathology. And you can notice that the exon 19 do with the better pathology response compared with the L858R. And about the 50% of the patient do with the co-mutation and 40% with the TP53 mutations. And for the primary endpoint, the 2-year progression-free survival rate, at the median time of the follow-up about 13 months, the maturity is about 58%. The rate of the progression-free survival in 2 years in the surgical group is about 27%, and for the control group is about 8%. And for the key secondary outcome, the progression-free survival hazard ratio is about 0.48, and for the p-value is 0.03. And the median progression-free survival for the control group is about 15 months, and for the surgery group is not retrieved yet. And for the subgroup analysis, we can notice that the pathology primary tumor we do with the intra-primary tumor resection group comparison. Try to find a signal that does means we can find some of the subgroup that has a better outcome in the surgical group. But unfortunately, currently we don't find any key sign for that. But still, interesting finding is that the major pathology response is not yet correlation with the improved survival in our study. But we still need to be interpreted very careful because only limited number and we need for longer follow-up time for that. And interestingly, that's for the oligometastasis status patient do with a better hazard ratio in the progression tumor resection groups. But for the polymetastasis status patients, we also notice with the better progression-free survival hazard ratio in the surgical groups. However, it's not significant yet. The effect still longer follow-up for that. And another interesting finding is about the exon 19 deletions and the L858R. We noticed that the exon 19 deletion do with the better survival, but we can notice that hazard ratio in the L858R has a better hazard ratio in the progression-free survival. This is a very interesting finding in our study. So in conclusion, the primary tumor resection 1 is the first pure thoracic surgery as a local consolidation therapy for after EGFR TKI treatment patients. It's not for cure. And most of the surgery perioperative outcome is very safe, and they all do with the minimal invasive surgery. For the pathology evaluation, we do notice that exon 19 deletions do with the better pathology response with the L858R. But the interim progression-free survival trend shows that the lower hazard ratio in the L858R subgroups compared with the exon 19 deletion groups. Currently, major pathology response is not yet correlation with the improved survival. The longer follow-up is still needed. So in conclusion, we believe this trial provides evidence to let the primary tumor resection as a local consolidation therapy, just like radiotherapy. And this can be a possible combination with the monotherapy EGFR TKI treatments, especially provide effect for those who was the worst treatment response in the systemic like L858R subgroups. Thank you for your listening. And thank you for the staff and my mentor, Professor Chen, Pei-Hsing Chen, and all the surgeons joined for this study, and my wife. Thank you.
Thanks so much, Dr. Chen. I think really driven by patient wants and desires, we're trying to do a very similar study in the cooperative groups in the US. I think this trial is really, really important and really pivotal. Next, I'm really pleased to introduce a presentation with a decidedly European flavor. Deborah Montague from Lung Cancer Europe is here with us to present her findings on lung cancer patient-doctor communications with knowledge and shared decision-making, a European experience. As somebody who's always trying to refine how I talk to patients, and as we increasingly have all these complex treatment decisions, I think that research like this is incredibly important. Deborah Montague has over 25 years of experience as a senior level in the pharmaceutical industry. Unfortunately, she retired for health reasons when diagnosed with stage 4 ALK-positive lung cancer over 8 years ago. Her personal experience with lung cancer has pushed her to advocate for better screening and prevention policies to improve cancer patients' health outcomes with promotion of early detection. She founded the ALK-positive Lung Cancer UK charity in December 2018. Deborah, I'm really thrilled to hear what you have to say about this topic.
Very much indeed. And as I say, I'm delighted to be here to share the results of our 9th Luce survey. So for those of you that don't know, Lung Cancer Europe carry out an annual survey amongst its members, which cover currently 34 countries, and we have about 47 different lung cancer organizations underneath us. So our survey last year was looking into the knowledge and shared decision-making for patients. Oops. I can't make. Am I right? Sorry about that. So previous studies had revealed gaps in lung cancer knowledge, and there were issues in accessing information and shared decision-making. So the aim was to understand the community preferences and knowledge impact on those decisions. So how do we do it? We carried out an online survey in 20 languages over 6 weeks. With the quality control was we did remove any incomplete surveys or non-European responses. And the responses were only regarded as complete if there were 21 questions answered. And the data integrated was used, the SurveyMonkey tools. So we had 1,432 patients took part. And 608 of those were caregivers, across 34 European countries. And we're also looking at descriptive analysis focused on general knowledge, access to information, and shared decision-making. So how did our patients do? So out of these that were surveyed, 65% delayed seeking care due to unrecognised symptoms, and 40% misattributed symptoms to other conditions. 22% completely unaware of biomarkers, and 24% didn't understand their prognosis. When we looked at access to information, 40% lacked sufficient information, and of those that did access it, 29% didn't understand it. So the barriers are very much around information processing, which we found in a third of the population, and also a third found it insufficient, and a third unclear. So overall, 89% lacked some form of support or information. Some of the challenges that were identified around this lack of information, the first was short consultations, poor communication, and complex information. So when we look at shared decision-making, 49% were highly involved in decisions, which was actually quite positive. However, only 56 of that percent actually felt heard. 60% said care aligned with preferences, which again was a very positive outcome, but 40% didn't value their involvement, felt that their involvement wasn't valued. So, and again, the barriers to shared decision-making are its complex information in half the cases, and poor communication in 38%. So, of the people in terms of making those decisions, 64% valued both life quality and length, and 1 in 3 prioritised quality. So the conclusions: communication issues were common across all the themes. The need for stakeholder collaboration on awareness and risk reduction. Healthcare providers must support shared decision-making, and enhanced communication strategies are vital for person-centered care. Thank you.
It's pretty sobering. Although it arguably doesn't reflect well upon clinicians, I certainly hope this is something that the press will pick up on. I think too many of our patients don't understand their symptoms or diagnosis, and over half feel unheard despite what we call shared decision-making. So I hope that people will pick up on this and continue that theme. It's really critically important work. Finally, I'm honored to have one of my most esteemed colleagues and friends, Dr. Charu Aggarwal from Penn Medicine, with us to present CAN-2409 with continued immune checkpoint inhibitor in patients with stage 3 and 4 non-small cell lung cancer with an adequate response to immune checkpoint inhibitor. One small note of conflict is that my wife is on the board of Candel. Neither of us had a pick of this drug, and I just realized that this morning, but I thought I should mention that just to put it out there. Dr. Aggarwal is the Leslie Heisler Professor of Lung Cancer Excellence at the University of Pennsylvania's Perlmutter School of Medicine, where she also serves as the Section Chief of Thoracic and Head and Neck Cancer within the Division of Hematology Oncology. Dr. Aggarwal, thanks for joining us. We're excited to hear the work.
Thank you, Dr. Stiles, for the opportunity. And this study is going to be presented today and at the 1 p.m. session on novel immunotherapy combinations. So on behalf of the entire study team and my co-authors, I'm pleased to give you a preview of our study of CAN-2409 with continued immune checkpoint inhibitor in patients with stage 3 and 4 non-small cell lung cancer with inadequate response to immune checkpoint inhibitors. I want to start with a brief overview of what CAN-2409 is. This is a gene-mediated cellular immunotherapy that starts with administration of CAN-2409, which is a replication-defective adenovirus carrying an HSV-TK gene. When this CAN-2409 is injected into the tumors, along with oral valcyclovir, thymidine kinase enzyme is released locally, releasing cytotoxic metabolites and leading to significant inflammation at the site of injection. This localized cytolytic mechanism combined with pro-inflammatory viral particles can then induce a significant local immune response that then can lead to systemic activation of both CD8 positive T cells and lead to responses potentially against both injected and uninjected lesions in non-small cell lung cancer. Based on a lot of preclinical as well as early clinical trials in mesothelioma and non-small cell lung cancer, we designed this phase 2A clinical trial of CAN-2409 plus continued immunotherapy in patients who had not had an adequate response to immunotherapy. These patients were enrolled in 2 cohorts, one where we only saw stable disease, and the second cohort of patients who were technically progressing on chemoimmunotherapy after first-line therapy. As you can see from the schema at the bottom, every patient received 2 injections of CAN-2409, delivered either bronchoscopically, which was seen in majority of the patients, or intratumorally with a peripherally injectable lesion. Each injection was accompanied with 2 courses of valcyclovir for 2 weeks each, and we continued the backbone, either pembrolizumab or whichever ICI they were on. We wanted to present safety as well as final overall survival data from both cohorts with a data cutoff of March 2nd to 2025. This study has been previously presented at various presentations, as you can see here. The baseline characteristics are presented here. We overall enrolled 76 patients, but you can see the per protocol analysis includes 46 patients, and this forms our evaluable population, that is, patients who received both injections, both courses of valcyclovir, and had 12 weeks of follow-up. You can see that the enrolled and the per protocol population is very similar in terms of demographics as well as tumor-related factors. You can see that CAN-2409 demonstrated a generally favorable safety and tolerability profile. Most treatment-related AEs were actually only grade 1 and 2. Grade 3 TRAEs were seen in less than 5% of the patients, and all grade toxicities denoted in this table. We did see immune activation in the form of chills and pyrexia without any grade 3 TRAEs in this category. So when we look at the per protocol population, as you can see in our cohort diagram on the right, we had 46 patients. In this population, at this data cutoff of March 2025, we are seeing a median overall survival of 24.5 months. Again, this is only 2 doses of the injectable agent with continuation of the immunotherapy backbone. We did also look for systemic or abscopal effect. It was measured in patients with at least 1 injectable lesion, out of which we had 35 patients, and we saw regression in about 2/3 of those. Just as a reference, historical control for median overall survival in this population is in the order of 9 to 12 months. What about patients in cohort 2? These are patients who had progressive disease at enrollment. We saw a median overall survival of 21.5 months with a median follow-up of greater than 2 years in these 41 patients. When we look at the non-squamous histology, amongst these patients in cohort 2, again, we see that these are the patients that have the highest overall survival at 25.4 months. And we did some novel flow cytometry analyses in our patients with cohort 2 in the non-squamous histology. And you can see that on the right, you can see our patients with the non-squamous population in this volcano plot. They are the ones who have the highest activation of CD4, T effector memory, CD8 T naive, as well as some memory B cells that are really increasingly important for these long-term durable immune responses. So in summary, this is the first time we are presenting long-term overall survival data. I think all of these results have to be digested with the caveat that this is a single-arm phase 2 study. However, this experimental treatment with CAN-2409 with valcyclovir in these patients led to a median overall survival of over 2 years after only 2 administrations of this agent. We observed a median overall survival of 21.5 months in patients with progressive disease. We have a long tail of survival in this small trial at 37% of patients alive at 2 years. And this is the possibility of precision medicine approaches in patients with greatest unmet medical need. One final note is that 90% of the patients had stage 4 disease. An abscopal effect, which is rare and not usually seen, and personally a skeptic, was observed in 2/3 of the patients presenting with at least one uninjected lesion. These trial results are very promising. They are supporting our hypothesis, and we are going to proceed with the phase 3 trial so that we can fully understand the efficacy of this injection, as well as immunotherapy continuation in patients randomized to standard of care chemotherapy. With that, I'd like to thank you for your attention.
Thank you so much, Dr. Aggarwal, for joining us and presenting that. As I mentioned at the top of this press briefing, we like to feature a prominent role for one of our patient research advocates. We're fortunate today to have Dr. Caleb Iguinu with us. Caleb is a dedicated advocate for cancer research with over 15 years of experience. He's a board member of IKCC, the International Kidney Cancer Coalition, and a member of the Patient Advocacy Committee at this meeting. Caleb has completed the Duke University Accelerated Anti-Cancer Agent Development and Validation Workshop, which is a collaboration with the US FDA aimed at helping participants understand the drug development approval process for faster delivery of effective cancer treatments to patients, something that's relevant for many of the talks we heard today. Caleb has also completed the IASLC STARS program and the STARS Scholar program. He's deeply passionate about driving change in cancer advocacy and research in Africa. Welcome, Caleb. We're excited to hear your thoughts.
Yeah, thank you very much to IASLC, and thank you to you, Dr. Stills and Chris, for inviting me. Glad to be here. I was talking to Chris, and when I got in, anytime I come to meetings like this, I try to drive it back home and bring it to my context. And there are so many things happening in the world, in America, in the UK, in the West in general. But when you look at what's happening in low and middle income countries like sub-Saharan Africa, you find out that it's so different. And I would about the screening, I would we know that. In Africa, a lot of the lung cancers that are seen are people who, don't smoke. So I would love to have, we to have more of, this kind of, trials and things in Africa to determine, what the epidemiology, is of lung cancer, in Africa. And for the shared decision making, funny enough, I was talking to a while ago with a clinician, and the clinician, in a joking manner, I was saying, I practice it in Nigeria. I said, we don't like it when the patients are educated. Why? Because they will ask us difficult questions. So I would love to see more of patients being involved in the shared decision making, and to see the number, in Europe. If we're meant to run that same, survey in Africa, it would be in single digits, and so want to see, more of that. And one thing that I am very hopeful, and I believe, is in terms of we need in Africa, we need a sort of leapfrog diagnostics technology. Where I see, something like the CT DNA, being something that would be easily accessible in Africa, and low-dose CT scan might be difficult to go into, the nooks and crannies of Africa. So I look forward to, we having most of this, technology as it's being developed, having it in Africa, just like we had in cervical cancer, where it was difficult to get pap smear to people, and the WHO approved then the they call it the VIA and V-line, where you use the acid to put in the cervix to check, the change and, know that it's, if it's going to be a precancerous, if there's a precancerous lesion there. And there was something they did, a single visit approach where they freeze the cells, so that it could help, the women. So I'm hopeful that, as technology is advancing, we'll have most of this that would, that will be easily accessible in Africa. So I want to thank, everyone that has presented today. Beautiful abstracts, and as you work, as in the patients, we are, glad and happy, and keep up the great work. Thank you very much.
Well, Caleb, thanks so much for those really thoughts, and we'll continue to be inspired by you and by our other patient advocates and patients in the room. Chris, are there questions in the back, or shall I start asking some questions?
We have 2 questions. One for Dr. Aggarwal. CAN 2409 is an injection right now. Do you see it becoming a pill form or some other, perhaps more accessible therapy when it matures?
Thank you, Chris, for that question. That's an excellent question. So currently, this is an injection that is delivered intratumorally. We primarily did it with bronchoscopic approach, where it was either injected into the tumor or into the nodes. We believe that it's important to deliver it in the tumor microenvironment to generate that immune response that can then translate into a systemic immune response. We likely think that this and other form of intratumoral injections will still remain injectables in the future, but could we start to space out these injections, or could these actually be like vaccines where we give patients an injection once a year? I think those are some interesting questions that we want to explore.
Thank you. Another question for Deborah. Based on the survey results, did you see any or detect any recommendations for clinicians about better communications training going forward? I know Dr. Stiles mentioned that, and I'd like to hear from the clinicians too about what kind of training they go through in their medical school, fellowship, and residency. That would be interesting perspective as well.
Yeah, I think it would be very helpful if we started with medical students with their during their training and to do some communication skills. It doesn't all come down to the clinician, though. It's a multidisciplinary team that look after patients. So there's nursing staff, there's the new navigator role. They sometimes have capacity to talk through what's going to happen with patients and what the next steps are and their options, maybe using more lay language. Maybe the auxiliary staff are more used to talking in lay language and therefore would keep the explanations very simple. And I think that's the problem with the communication. It isn't always that the information wasn't shared. I think the challenge will be is whether patients understood it, and they'll always sit there and nod. And walk out the room, and you still don't know whether they understood or not. And I think it's not just the area of treatment, it's into the area of clinical trials and enrollment in clinical trials. I've seen some protocols recently, and I was led to believe they'd gone through a review process. So I thought, oh, it'll only take me a couple of minutes to have a look at them. They've checked them, and it took me many hours because of the language that was being used. So I think that's bound to impact enrollment in clinical trials, because it's easier to say no than to keep asking questions if you don't understand. And so it has a real impact if patients don't understand what's going on. So it's important right across the spectrum.
Thank you. We have 2 questions for Dr. Bai. Let me read these to you from Laura Cohen. What are the current eligibility criteria for consolidation ICI, and why is it important to improve personalization of this treatment with ctDNA measurement? I'll let you digest that question before I go to the second one. I don't want to make it too difficult for you.
Dr. B, that was for you. The current eligibility for following patients with ctDNA in this setting.
Yeah, I think we cannot, we don't have high-grade evidence for clinical use of ctDNA monitoring during our clinical practice. And we try to do some research work to find the value of the ctDNA monitoring. I think maybe in the future, after the evidence from a prospective study, we can use this to guide our consolidation IO.
Very exciting. What was the second part, Chris?
The second question is, based on your findings, do you think that clinics should be routinely measuring ctDNA during treatment for LS small cell if they aren't already? And if so, how feasible is widespread adoption of this strategy? We only give the easy ones to you.
Basically asking, is this ready to be adopted to the clinic now? Or I think, as you alluded to, probably needs bigger trials to confirm.
Yes, maybe we could design, but I think before it can be used clinically, the most important issue is the cost. The cost is so expensive, I think. Yeah.
Great. Chris, while you're looking for the next one, let me ask Dr. Shum, super, super important, and really important for the press to understand that about 40 to 60% of lung cancers are diagnosed in patients who would not be eligible for screening. So we need to find a pathway to look for cancers earlier in patients who are screen ineligible. The FAN study is really the first such study that I'm aware of in the US to do that, and it focused on a group we know to be high risk, female Asians. What other groups do you think should have similar studies like this? This was a really pivotal, but we know that there's other pockets of lung cancer. How should we think about that moving forward?
Thank you. So yes, certainly, my study represents just one potential high-risk population group within the non-smoking population, but there's certainly others. Other ethnic groups for sure need to be explored, particularly Hispanic and Latino populations, which are known to also have high rates of driver mutations in their lung cancers that arise in a non-smoking person. Family history has been heavily looked at and reviewed here at this conference as well, and so I think certainly more work and studies to see if family history can be something to use as a selection criteria for eligibility might be another way to go forward in this population. And of course, a lot of information about air pollution and our exposures to that as to whether that might play a part in development of lung cancer. So, there's a lot to take in, but, we're hoping that, studies such as FANS is like the first step to open the doors for more studies to really explore expanding these lung cancer screening guidelines.
That's great. I'm confident that it will be. May I ask Dr. Chen a question? Chris, you got something?
Absolutely. We don't have any more questions back here.
So Dr. Chen, really, really important, right? We've got a lot of medical oncologists in the room who have these great tools at their disposal with stage 4 lung cancer, targeted therapy, many drugs, over 80% response when they're given. But we know from the neoadjuvant studies that they're not killing all the tumors. So we know that these patients still have persistent cancer cells. So ways to get rid of them are critically important. I think it extends treatment of the original drug and potentially extends life. Our patients in the US, there's patients flocking for this idea, which is why we think it's really critical to do a trial. So one question is, are patients proactively seeking this trial? And then the second question would be, does the type of local therapy matter? Surgery versus radiation, obviously there's debates and other things, but do you have an opinion on that as well?
Right, I answer the second question first, and as I think, currently, just like in the early cancer, I believe that the psoriatic might provide a better disease control. I think the rationale might be similar. If currently we can use the radiotherapy in the late stage, why not can use with the primary tumor resection just like the surgery? in previous, we think we want to cure the disease, but currently in advanced stage, we understand currently not so suitable to cure disease in this kind of patients. So the role of the surgery might be better disease control. So if we can do the surgery safely in this kind of patient, I think it might be a better role compared with the radiotherapy. And the second, I think because this kind of patient might be live longer than before. So I think the life quality sometimes is very important. So for the radiotherapy, sometimes the radiation pneumonitis will influence the lung function and their life quality. So if the patient we currently do with the surgery, most of the case patient can do their daily life. There won't be any influence for the further. But still, we need to find that what kind of patient what we can select. I think not always the patients with the disseminated lesion that we can do with the surgery. And importantly, for the distant lesion, in our study, we also do with the radiotherapy. So our focus is that for the primary tumor resection might have a better role compared with the radiotherapy. And can you repeat the first one? Sorry.
Are patients really seeking this out, these types of therapies in your country? Like patients come to you looking for surgery with stage 4 disease?
Yeah, I think the patient might do with the in advanced stage also, especially with the oligometastatic patient populations. But still, I think the systemic treatment still be the first line, and most importantly, they need to be under control. Then we do with the lesion to control it. So I think sometimes it's not suitable for all of the systemic treatment. Is just like if we do with the immunotherapy, the lesion is almost managed. I think sometimes the patient don't need to do with the surgery for that kind of patients. But currently we pick up the population is about the EGFR TKI because we know that the EGFR TKI is more likely as a cytostatic agent. The cytotoxicity effect is not so much. So most of the patients will inevitable to progress after 1 to 2 years of observation and treatment. So in this kind of patient, we think primary tumor resection might be more successful. But in the future, just like we might expand, just like the section name of the expression of horizontal of local consolidation therapy. Maybe we can try other agents also and include more and more patients to do this in the advanced stage. But still, I think the problem and mission in future is that how can we pick and select the patients that can be received the surgery for that? Yeah.
Absolutely. Dr. Aggarwal, may I ask you a very challenging question? I'm sure you're up to it, but it's something that I really want the press to take a hold of this idea. We have drugs like you showed in the study there, viral therapy basically. We have drugs that we would traditionally call vaccines, but are that sort of antigen-directed therapy. And we're seeing incredible promise and hope of combining these things with immunotherapy. But at the same time, at least in the US, we're seeing this tension about viruses, vaccines, about the potential badness of all these types of drugs. How do we balance drug development and sort of patient fears and worries that's been driven by a lot of things in the press with the need to sort of make forward progress for our patients with lung cancer? And do you have any specific thoughts about these types of therapies?
You weren't kidding about the complicated question. So I think you highlighted a key concern that is surrounding this idea of vaccine-based research as well as intratumoral therapies. I really want to emphasize that we need to continue to do what's best for patients, and we need to be grounded in science. But most importantly, we need to get the correct, authentic message across. I think there is just so much disinformation out there and misinformation out there, especially as it relates to vaccines, not just for cancer, but vaccines in general. I think we all as a community have to remain strong and rooted in science. There are a lot of personalized vaccine approaches in clinical trials right now for high-risk disease, for high-risk early-stage non-small cell lung cancer, as well as in the perioperative and stage 4 setting. So I think we just have to keep going. We are at the forward front of this, and we are the soldiers that have to keep marching.
Great answer. I knew you were up to it. That leads to maybe Deborah too, right? And so some of this work with educating patients and talking about these things, I mean, these are other barriers, and I think personal perception of things is a big barrier that you didn't talk about as much, but I know that you've thought about. Do you have any sort of comments on that? Like balancing the fear for patients with some of these new trials versus the possibility of making an impact on their disease.
Yeah, I think it just comes down to communication, and I think it's important to maybe discuss maybe what the elephant in the room that patients may be thinking but haven't verbalized. There is a lot of misinformation out there. A lot of clinicians now are starting to recognize the value of patient advocacy organizations where you can get very accurate information, and so we're seeing more and more patients being referred to patient advocacy groups, and that gives me hope that then in the early days patients are getting more accurate information that they can then spend time disseminating and also meet other patients in the same boat.
Absolutely.
And I think there's nothing like talking to another patient with the same condition, and also ones that are living so long. That's the inspiring bit. But yeah, it is a worry. Your instinct, as soon as you are diagnosed, is to hit the Google button, and it's the worst thing you can do.
Well, thank you, and thank you, Caleb, for spreading the word and spreading the information. Chris, other questions back there? Okay, well, thanks to, yes.
Actually, I have a question for Professor Shum, because I come from Taiwan and we do a lot of the lung cancer screening. So I'm wondering, does there any evidence about the biology hints or the evidence for why the non-smoker young female do with a higher cancer prevalence? And the second is about what do you think about the AI will you suggest to use for in the future? And if you do so, you want to do in the screening or use in the differentiation? Because I think the design will be different for that. I'm looking for your opinion.
Yes, great question. Of course, I admire the work that's been done in Taiwan and in your hospital. But I think we all are faced with the same question, as we don't have the clear idea of why Asian women with no smoking history are a high risk for the development of lung cancer. So we're hoping that as we continue on this, we might uncover some answers as we look at looking in a detected population. For your second question, absolutely, we hope that AI, radiomics, and also blood-based assays might help to complement screening in this population. As I highlighted, that things like ground glass opacities are a diagnostic challenge. You really can only get a diagnosis by having a surgery or biopsy, but if there's something we could do prior to that to help predict risk of lung cancer, it would be enormously helpful in screening this population.
Thank you.
Great. Well, thanks so much to everybody on our panel. Really appreciate the time.